Welcome to Conversations in Reproductive Medicine, an RBMO podcast, the official podcast of the journal Reproductive Biomedicine Online, hosted by our co-chief editors, Professor Nick Macklon and Professor Juan García Velasco. Our first series of podcasts meet the people behind the papers, exploring the evolution of assisted reproductive technology through the eyes of the groundbreaking scientists who have guided its development. In our first episode, Professor Jacques Cohen shares his journey from the Netherlands to the forefront of reproductive science in the USA, discussing the early days of IVF with Sir Robert Edwards at Bourn Hall, the challenges faced by the developing field and pivotal moments that shaped his career.
Well, look, it's great to have Jacques Cohen here for our first of these podcast discussions with Juan and me, trying to get to know the scientists behind the papers that we're also familiar with over so many years. I mean, Juan has been very important too, but Jacques has been even more important, as to be said, in his contribution to the society and embryology, to what we do. And it's really a great honor for us to welcome Jacques. Thank you for coming and joining us today.
Yeah, thank you very much for the invitation. I'm a nervous wreck, but I'll try.
Yeah, I mean, this is about a fireside chat, really. But it's just a chance for us all to get to know you a little bit better. We know your science and the contributions, which have been, recognized with so many prizes through your career and this year as well. But it might be helpful just to understand a little bit about where you came from, Jacques, and how your career started and took you through the contact you had with Bob Edwards and then on to your move to the US. So where did it all start? Was it in Rotterdam that you began?
Yeah, you're well familiar with that place, of course. Yeah, I started with García. It was in June 1976, so yeah. You can count, that's 50 years ago. It was not for my PhD, it was before my PhD. PhD started in 78. This was for my master's program to finish the master's, which I had started a few years earlier. I was a student from Leiden, but I would just commute from Leiden every day to Rotterdam. And this was great because it was clinical embryology a little bit, but it was investigative embryology mainly. We call experimental embryology in those days. And that was what it was about. And I chose the topic of parthenogenesis. And so that's how I started. And I was sold. The first day I was in that lab, I knew this was going to be my career.
And you went on to join the Rotterdam group, is that right? The earlier IVF, or did you do that after you worked in?
Okay. The Rotterdam group, there's Bert Albert there, the young doctor at the time, he was a resident, and Gerard Zeilmaker, and to some extent I was involved in forming a team. It was in 78, the year Louise Brown was born. And in 79, they started doing egg retrievals, but it was an experimental protocol. And so the ethics board, which was the department head of OBGYN at the time, Drogendijk was his name. Very nice man, very constructive, but he was scared of this. He said, well, this is an experiment. It took these guys in Britain ages to get to this point. So when we started, let's be careful. You can retrieve eggs, you can transfer embryos, but you have to do it as part of an investigation that's already routine in a patient. And that was, of course, the use of methylene blue to show the patency of the fallopian tube. And so we transferred fresh embryos, like everyone else was at that time. And we called the embryo catheters blue catheters because they were full with stain. And so, of course, nobody became pregnant. It's never been published and wasn't a ton of patients, but was enough to make an impact. And we got embryos. We also froze embryos in 79. And in 1980, we froze human embryos at the 8-cell stage, and most of those survived. They didn't look any different from mouse embryos that were frozen. Yeah.
Because in Rotterdam, wasn't it? It was your group that carried out the first successful frozen embryo transfer. Is
that is the group I was associated with, but I had already left a year earlier to go to Bourn Hall Clinic and join the embryology team of Bob Edwards.
Yeah. Okay, so when did you do that, Jacques?
That move was early 1982, and I think the Rotterdam team started doing real clinical procedures at the end of '82, so shortly after I left. And I joined a team in Bourn Hall. Very lucky to be chosen for that, together with other embryologist. There was Carol Verheely, and the embryologist that was there already started probably about a year earlier than me was Simon Fischel. And so the three of us took over from Bob Edwards. Bob wanted to not retire from embryology. He was still going to stay, had a scientific director of the institute, of course, and be an embryologist. But he was moving away from activity. He had only done about an estimated 500 cycles at Bourn Hall Clinic after it started at the end of 1980. So I came about 14, 15 months after that. And so actually it seemed like enormous experience, but it wasn't. He had achieved an enormous thing from the success rate of about less than 1% coming out of Oldham, Manchester, going out down, setting up the clinic in Bourn outside Cambridge. He was able to move that from less than 1% to about 20%. That still sounds like a ridiculously low penalty, but it was considered, at least by all our visitors and the way others commented on our work, as the highest penalty rate in the world.
Well, no, very, very early days. But maybe in 50 years, they will laugh at our success rates that we have today. So.
I hope so. I hope they do, right? We keep on climbing, and we're getting better each year. Yeah, we're getting better.
So how do you move from Bourn Hall to the US? What took you there?
That sort of question is how and why. That was a mistake. I should have hung around for a little longer, but Bourn Hall I was only there for about 3 years. It was an incredibly ambitious environment. Bob and Patrick and Jean Purdy and others were great, but they were under tremendous pressure from the media. There were lawsuits about blasphemy and other reasons. They were suing the BBC. They were suing the Time. There were 5 major lawsuits going on in the background. There were visitors every day. There was a visitors committee. Sometimes buses arrived unannounced. And so that daily pressure of the visitors expecting everything from us, that was after 3 years sufficient. And I decided to move. And frankly, I still regret that. I think I should have stuck around for a little longer, at least for a couple of more years. And so I had opportunities to go to Australia, some countries in Europe, and also the United States, and compared all of that very systematically and chose, of all places, Atlanta, Georgia, to go to instead of, for instance, New York or Yale University or Boston. I chose Atlanta, Georgia for reasons that had to do with calmness. I wanted some calmness after the upheavals in Bourn Hall Clinic.
Why do you regret it, Jacques? Why do you regret leaving earlier?
I don't know if you know that history, but about a few years later, Bourn Hall was on the verge of bankruptcy and had overspent this idea of building a clinic for inpatients. And I assume you both know that that first clinic, Bourn Hall, was running on an inpatient basis. Patients during follicular stimulation and monitoring were kept inside the clinic, and that was based in a bunch of porter cabins, they're called in Britain, temporary facilities, put together like Lego blocks. Quite fancy, actually. But they were built between the stable block, which were some of the laboratories, the more diagnostic laboratories, and the Bourn Hall itself, which as a patient facility could not be used to house patients for durations of 7 to 10 days. And so that inpatient aspect was one of the reasons that Patrick and Bob felt was instrumental to getting that success rate well above others who were trying IVF, other clinics that was being set up worldwide. They felt that was instrumental, and there was never any evidence for that. And I mean, not as evidence-based. I mean that from the perspective of just looking at retrospective data. There were so many things changed during those years that you really could not point at why their success rate was a little higher than the success rate of others. But since nobody else, I think, no other clinic had that inpatient quality to it, they knew they had to take this temporary facility and build what basically was an inpatient hospital. And it was built in the style of the hall and the style of the block, of the stairwell block, and therefore was incredibly expensive. And so that they were seeing well over 1,200 patients a year. So this was from the beginning very large clinics for that time, and that was not enough to break even, and it was certainly not enough to support that build out, which looks fantastic. But I think that was a failure in the making. I must say I regret this because I never brought it up with them. And I think that I can only guess, but I think that's the same for the other embryologists who left at the same time. So I think we saw that coming. Sorry.
No, sorry to interrupt. It's very interesting time because I don't know if it was as clear as it is today that the embryo was the key factor for the success and the lab. And maybe at that time, it was early times for embryology, early times for reproductive endocrinology, and maybe that they considered that keeping the patient in-house would be significantly better. How was it at that time?
Yeah, so all of that was experimental, gaining very little information, bits at a time. Every month counted, every day counted. None of it was set in stone. It was a tedious arrangement. And nevertheless, we gained a lot of information, spread the word. We're sharing our data, we're sharing our procedures. But of all the visitors, nobody bought into this idea of inpatient. But you're right, reproductive endocrinology in those days was a black box, hadn't been sorted out, particularly for IVF purposes. This was the days where they were debating clomiphene citrate and Bourn, right? There were early days for gonadotrophins, early days for monitoring. The assays were horrendous. These were all qualitative assays at best and difficult to obtain. Estradiol's were once a day from blood. That was an entire lab set up by itself. Now that it's a tiny machine, right? So it was something else, really, really, pretty spectacular, at least from my perspective.
I mean, it must have been very exciting. Every day was like a new discovery. What we're going to learn today, I guess.
Yeah. So we had a meeting like this. We had a meeting every day like this at around lunchtime. It still happens in some clinics worldwide. It's not that the reproductive endocrinologist sits behind a monitor as a nurse and quickly goes to the patients. It can even be done remotely. No, it wasn't like that. The entire crew was combined in one room, going over the results and speculating why 4 out of the 5 results that day were negative. Speculating about it, going back and forth about it. How can we improve? What is going on? It's actually dramatically frustrating, particularly for doctors and nurses, I think, because they had to talk to the patients, and most of those stories were negative. Yeah.
And I assume those patients also, had a huge faith that somehow it was going to work, even though most of the times it did not.
Yeah, but some would come back, Juan. That was an amazing thing. Some would come back as they do nowadays. Some of these patients fall through the cracks and become unknown failures, and they keep coming back. There were people there who tried 12 times. The champion was close to 20. And so they kept coming back because the statistics pointed out that was not necessarily a bad thing to do. Yeah.
And when you decided to move, Jacques, how did Bob and Patrick react? I mean, did they see this as sort of spreading the word, getting the word out there, or did they see that as, why are you leaving us?
Oh, yeah. Yeah, I think there may have been a little bit of that first aspect, but I think it was mostly disappointment. These were difficult conversations.
Right.
And as I said, I had my doubts that leaving was the right thing to do. I really had strong doubts, and I didn't know of everybody else or all the two other embryologists that they were also had these had firm decisions. Particularly Simon, I was very surprised to hear a few weeks later that he had made a similar decision, and so this was not easy at all. Yeah, I'm not proud thinking back on that. I'm proud what I did there. We were the first to freeze human blastocysts, the first to tackle male factor infertility with IVF. That was not the intention. We were going to do microneedling, but we never got to it. No funding, and so yeah.
Amazing. And so you landed in Atlanta. You know, there must have been a bit of you said it was quiet. What was going on? Was there any IVF? Did you set it up from absolute scratch?
Yes, but yes and no. There was IVF, but they had been very unsuccessful. This is the group that nowadays is called RBA, stands for Reproductive Biology Associates. They are part of a bigger network in the States. Almost all clinics are now part, like in the UK, of networks. Yeah. And at that time, they were established about a year earlier. They had a pregnancy and a live birth, first in Georgia. But they also had an association with the University of Georgia, which was a FAT school. And the department head there was a man called Ben Brackett, who really was, I think, really the founder of animal science, larger domestic species IVF. Ben Brackett, well known to embryologists are listening in, at least from those days. And so that whole package was attractive. I was given carte blanche to redo the lab. And carte blanche to at least get some grip on reproductive endocrinology. For both of you, that sounds a little strange, but in Bourn Hall, Bob Edwards was clearly in charge of follicular stimulation and triggering ovulation and establishing the timing of the procedure, because we did not know, right? There was no downregulation. There were no agonists, no antagonists. We were in the blind about when ovulation was occurring, even so we had to trigger if we could. It was only ACG. We were guessing everything. Ultrasounds were blurs on a screen. There was really no. You couldn't really argue much about the ultrasounds. We were trying. So Bob was very much in charge, and apparently had been in Oldham as well, because he was very much interested in endocrinology, going back all the way back to the 1950s, where he and his wife, Ruth Fowler, together, they figured out how to stimulate mice in the lab to get ovulation and time that process with PMS and ACG. They were responsible for that. So he had done that in at least one mammalian species and felt very much that he needs to be part of that. So when I went to Atlanta, for at least a year or two, I was kind of trying to do the same thing, because I was taught in that way that wasn't just embryology, it was also follicular stimulation.
No, this is amazing and actually fascinating when I hear you talking about these times, which is not, 50 years, but not really that far away in history. And now you talk about automation and 3D scans and all these things that are completely different.
Yeah.
It's such a huge advancement in the field. So then from there you moved to New Jersey, or?
I moved to New York, from Atlanta to New York. It was 4 years after that, 1989, moved to Cornell University Medical College and worked with Zev Rosenwax. I met Mina there. Mina Alicani was already there before me and was the senior embryologist in the lab. Michael Bedford, I think the man who really discovered capacitation, was a major influence in the discovery of the acrosome reaction. Had gone into, a few years before that, had gone into clinical IVF, which was surprising to me. He was a really, really outstanding basic scientist. I just didn't know that basic scientists kept coming into this field with an interest in clinical IVF, and he was one of them. And so I joined that team, and later, just a year or two later, Jamie Griffith joined with his interest in pre-implantation genetics. I think it was just a year later. So this was an interesting team to have, and it was a large clinic. So suddenly had a lot more information from gametes and embryos So for me, that was an obvious move. Yeah.
And was embryology getting established then as a career option? Because I
Yeah.
suppose at the time when there were just a handful of embryologists in the world.
Yeah, well, it's not a handful. By the time we got from 1982, by the way, before I moved to Bourn Hall, I was unemployed because nobody in Holland wanted to set up clinical embryology, with the exception of the team in Rotterdam. Nobody else was interested in going into that pathway. By 1989, 1990, when I moved to New York, that was completely different. People were already collecting data. The ASRM at the time was called the AFS, American Fertility Society. They were collecting data from 1986 onwards. It was on voluntary basis to prepare interested parliamentarians, senators, as well as House representatives, for the need to report on data and outcomes, which was unique in medicine. That had never been done before. Very similar to the voluntary licensing organization, which preceded as HFEA in the UK. Yeah. And it's interesting that we represent these three countries, but it was Spain first, I think, in 1986 that regulated IVF. And then the UK and the United States followed. The United States never really completed that procedure. They regulated a lot of aspects related to quality control and data reporting, but not much about medical practice. By 1990, this you could in 1992, the first exams were given to prospective laboratory directors to be licensed in what was called the high complexity laboratory directorship. Which I was one of the first, I went with the first group. There were about 60 of us to take an exam. It was actually 3 exams, and that's how that started. So I think it's surprisingly fast. It sounds not fast, 82 from 1982 to 1990, but it's a huge difference already. Very much organized.
Yeah. So we know many aspects of your work, Jacques, but I suppose from shortly after that time, you became quite quickly associated with genetics. That's also with cytoplasm transfer. I remember hearing about that in Holland, where we were all shaking our heads with disgust at this crazy guy in the US, which we enjoyed doing. So, there was clearly a very exciting time came from the 90s. You'd established this embryology, you'd established a couple of labs, you were working with really pioneering people. How did you get into the genetics side of it and into these more esoteric interventions that you started?
So, well, I think the first thing, that is a good question. How did that happen? It started with micromanipulation. We had to sample the embryo at that time, getting blastocysts. The whole culture system was nothing like what it used to be. And so I was interested in the micromanipulation, particularly for the purpose of microsurgical fertilization or assisted fertilization, is what we called it, and my team was involved in, I think, the first pregnancies from micromanipulation. That was all happened in Atlanta. At the time, I was also associated with Emory University, which supported an experimental embryology laboratory. They were incredibly generous. So being a micromanipulation expert, I think it was Jamie who around 1988 sent one of his residents or students down to Atlanta, and together with Henry Moulter, who was a big name in the early micromanipulation days, we taught this person biopsy, not knowing how to do this ourselves. And so a year later, or 2 years later, Alan Handyside and his group in London obviously published the first case doing genetic testing in a case of genetic disease or at risk of genetic disease transfer to offspring. And so now suddenly IVF moved from infertility treatment to somewhere else. And so this was a big moment, and that publication is from 1990, but the work was already presented in 1989. And so my micromanipulation experience, as well as a career interest in genetics, Jamie Griffo joining a year after Jamie, Santiago Munet joining, that brought that whole team together. And so we were we were performing the first PGD cases, as they were called at that time, in the United States, after Bob Winston and Alan Hennyside, of course, and established a new organization called PGDIS, which still exists, and that organization, the members of it, predicted that this would become a big thing, and it did. And that's how I got involved in that field. But it was particularly when Santiago Moner, who had a PhD in genetic research, he was a cytogeneticist, when that happened in 1992, and we started studying abnormal embryos first, and then a year or two later tried our first PGD case for chromosome testing. And the first birth was in 1995 of PGTA, what we now call PGTA. So that's that history. And I think that whole thing came together also because often freezing was needed, and slowly we were getting better at freezing. This is still the old-fashioned slow freezing. Vitrification started really quite a bit later than that. Had been done in animal systems in the 1980s, but that started really, I would think, at the end of the 1990s. Yeah.
You know, one reason why it's such a pleasure to speak to you, Jacques, is that right through your career, you've been at the sharp end of where the field is. You know, right from the days with Bourn Hall, Rotterdam, coming into the US, blastocyst culture, genetics, cytoplasm transfer, and now, of course, most recently, your work, automation of labs. You must have got used to, being criticized for being perhaps a little bit too ahead of things. And, you've very interestingly said that a couple of things you regret bringing things a little bit too quickly. But on the other hand, without the drivers in our field, we don't make the progress at the rate everybody was demanding at the time, which I think we need to remember. But did you find that working in the US, this comes back to Juan's question really, did you find the environment there was a bit more supportive of this sort of innovation than you'd been used to? And did that encourage you to stay there really and make your career there? Was that part of the reason?
I think so. Even on university levels, the support was clearly there. The investments that were made in setting up new clinics and building out state-of-the-art laboratories, that's always been there. I mean, I see that. I remember visiting Juan's laboratory in Madrid 20 years ago, and I was blown away. But that came probably a little later than what the United States had already done. And that conversion is not across the board, because we're talking about a large country with the demand for infertility treatment. So there certainly was a drive from patients.
Okay. Yeah.
There was funding, and it was clinical funding. There was no government funding. I hope you realize this. There's never, ever been a single grant given to doing a randomized trial when that involved creating embryos or from fertilization onwards all the way to embryo transfer. There's not a single dollar that the NIH has ever spent on the area of assisted reproduction. So it all came from clinical funding, basically.
So a lot of fighting for funding, fighting to move the field forward, and you've mentioned a couple of areas or moments where you feel, okay, maybe I should have made different decisions. But looking back, I mean, you'll be very proud of a lot of what you've done. I mean, what would be the contributions you've made to our field that you would be most proud of now?
Maybe in general, I think there are a couple of them. I think being associated with teams and others who made this work with me, and that also applies to individuals and groups outside my little area. I think I've been part of that for a long time now, with some quiet moments, a couple of quiet years in between. It's been actually really a pleasure to see that. And you're quite right. I think you're defining this quite right. Things in hindsight where I would think that, well, we were too early. Like I mentioned, Santi and I pushing PGS, as it was called, PGTA now, pushing that when the embryos weren't ready for it. They weren't good enough. And when there was no vitrification, no survival rates after freezing as now, which is, what the KBI is 98% survival. Well, we had 70% survival. It's completely unacceptable nowadays. So pushing it a little early, definitely, over quite a long period of time. I think you would probably say the same. Yeah.
But a lot to be very satisfied with your career, which is still as active and exploratory as ever.
Yeah, I'm halfway.
So what's your next thing? I mean, we've been following, and I really enjoyed your talk at Fertility 26. Many will have heard it, and I'm sure you've given that talk in other conferences around, which I thought was a very balanced view of where we are with automating the lab. Do you think that is going to be the major area of advancement now, or where do you think the excitement's going to be in our field over the coming years?
Artificial intelligence in all areas of medicine is going to play a major role. I hear all the time that assisted reproduction has been behind. I hear years, 10 years, 5 years. And that's probably true, but we're catching on fast as a field. We're still in the early days of AI for decision making. There's now AI for automation, which is making a machine understand, well, this is the tip of a pipette, and this is the sperm in a microneedle, and you can follow it here and give us feedback that keeps track of that 100% of the time. So there's different AIs there: AI for automation, AI for decision making. And I think it's very early days. I think on the other hand, if you look at the literature of automation attempts, such as from microfluidics, I think that's really part of automation. That started around the year 2000 with Gary Smith in Ann Arbor and Professor Juan at Toronto University. This has been around for a while. And when you get this start of 25 years or so of these two groups and others in quite a few countries, there is a head start. So when we look at the literature, we stand on the shoulders of giants, truly. They're just not known to our clinical field, but there has been done a lot using animal systems, automatic injection of nuclei, holding embryos simultaneously, like 10, 20 embryos simultaneously in their own little areas. This was in 2009, presented at ASRM. In a video, I was floored when I saw it. And so I think we have been patient in this case. It has been a patient development. I think now you see commercial efforts, but a lot more efforts from universities who are jumping on this and are looking at ways to improve. Harvard University and with the collaboration of Danny Sackers and Michael Alper at Boston IVF, that paper that came out in January. At the same time, we had a paper published that same month on all activities in RBMO line, right? All activities on day 0, sperm prep, egg isolation, egg donation, even ICSI. Not all of it automated. I mean, the paper is clear about it, but things are now happening. And people are going into this and understanding that this is the next period of drivers. I was just invited to give a talk on the future of IVF by an organization in Asia. And frankly, I always used to talk about automation, maybe not AI, but automation. And now I don't know what to say to them because I've no idea what that now means. I can't look beyond into automation. I think we are all on board that this is going to be the next phase. It's not going to be a few years. This is now set in stone. I hope I can contribute.
I think, going back to Nick's comment, you have been always like a little bit ahead of times. Always like, I can understand why they invite you to speak about the future, because you see the future coming. You see embryology and you see embryo biopsy and automation. And I guess I understand that it's all about getting in the right team and with the right people, but there's always inspiring people there. I mean, if you had to choose one hero, someone who really inspired you to move forward and to be so upfront in so many different topics, do you have any individual that was really inspiring in your career?
Well, of course, it's like, this question, it's a great question. If this is about somebody who is alive, then that's a question I'd rather not answer, because I would be hurting other people's feelings, and I really couldn't point to that. But if it's about people who are not alive anymore, then it becomes history. And obviously, incredibly fortunate to have worked with Bob Edwards after his achievement of the first birth with Louise Brown a few years later. I think that set me up in a major way. This guy was so inspiring, and we stayed friends till he died. And so that was a 30 years period for me. I think that was I think Bob Edwards was my big inspiration. But we in history we overlook people or don't know even about people. Anthony van Leeuwenhoek, guy from Holland in Delft, who was not even a scientist, and science already existed a little bit in those days. Who, for his own trade, which was basically the garment industry, for lack of a better, but those words were probably not used at that time, but that's what he was trading in. Developed a microscope. He was always good about carving lenses, that's what I understand. And he developed a microscope. It was a handheld. He could put it in his pocket. It was 5 centimeters. With a lens that was better lens than ever made before. Okay, and he wasn't a lens maker. He wasn't a scientist. And in a few years' time, discovered microbial organisms. He discovered algae. He discovered bacteria, and he discovered spermatozoa. Okay, now that's unbeatable. I think somebody who's absolutely unknown in biology at that time, sciences at that time, medicine, coming from outside like that, and modestly. Had difficulties articulating, had difficulties writing about this, wrote to the Royal Society in London to get an article or two published, and of course got a lot of pushback because this came out of the blue. They couldn't comprehend this tiny life. But the first spermatozoan animal that he tested was, of course, himself. So he discovered human spermatozoa before he looked at other species. It took him a long time to realize what this was all about. But he did that before, I think it's 250 years before the discovery of, do I get that right? It's 150 years before the discovery of the mammalian oocyte, early 1800s. So it's quite, I mean, that, he's on a pedestal. Yeah.
So, yes, quite a story. And what's interesting, I think, about these people from that time is how, they often had several careers. They were often doing 3 or 4 interests. They're all polymaths. And I suppose it raises a question for us to you, Jacques, about, if you weren't a scientist, what do you think you'd do? And, who is the Jacques outside science? Are there other things that light your candle beyond looking down a microscope and coming up with the next crazy idea?
Well, I would have been very poor, because I would have been an artist.
Really?
So I would have been obviously struggling. But I now do arts on the side, and I'm enjoying it very much. Yeah.
Is that painting or?
Yeah, well, it's digital rendering.
Oh,
yeah.
Okay.
Yeah,
Right.
yeah.
That's interesting. Yeah. And what sort of things do you like? Is it sort of still life or landscapes or?
It's a number of areas. I like still lifes. It's very much true. But I like portraits probably the best. Mm-hmm. Okay. That's still my favorite. I also like architecture, and therefore houses or buildings, and getting different impressions of those. Enjoy it a lot. Yeah.
That's great. Well, I think thank you for speaking. We've been going for an hour, so thank you very much. It was really fascinating to listen to you, Jacques. I mean, I think we both had the pleasure of knowing you for a long time, and obviously your history with the journal and as a predecessor to ours, and taking the journal to where it is now. It's been a pleasure for us to work with you and still to do that. But I think we both got new insights, didn't we, today, Juan, about Jacques, which I'm sure many people will find very interesting.
Yeah, I think it's a privilege to have you, honestly, and listening to these stories like it was yesterday, and being able to share this with mainly our juniors. I think it would be fascinating to see this living legend speaking to us. Thank you so much.
Oh,
Thank you very much.
Really enjoyed speaking with you. And next time we talk about you, okay? Not about me. All right. All right. Take
Bye-bye.
care. Thank you so much.
Thank you so much, Jacques.
Pleasure. Good talking to you.